So we have no disclosures to make today in terms of a financial arrangement related to the content of this activity. And today we will be covering the stages of change in the spirit of motivational interviewing. These slides are adapted from previous presentations by our own Dr. Bott, as well as Dr. Fernandez and Dr. Lindsay. So our objectives today are to identify the core concepts of the trans-theoretical model of change, as well as the specific components of the stages of change in order to apply these concepts to assessment and treatment. We're going to review the foundational principles of motivational interviewing and its basic components as they apply across clinical settings. And we're going to develop an understanding of the philosophy and application of MI in the context of case conceptualization and treatment planning. I will say these are some really big picture concepts that we're covering today, and I'll have to keep a really brisk pace to keep it under half an hour. So if there's anything that you'd like more detail on, please let us know in the Q&A so that we can circle back. It would be nice to be able to get in some more detail. So starting with the trans-theoretical stages of change model, this is an evidence-based model that matches where a patient is at with what they need interventionally in order to benefit from treatment. So remembering it's not an intervention in itself, it's really more of an assessment tool that helps you to select the appropriate intervention. The stages of change model is not part of motivational interviewing, and I'll talk more about that in a bit. But it can be utilized with MI. It's very beautifully complementary with MI, and it's an excellent guide for assessing what type of intervention will help most. So in a moment, we'll go through each one of these stages of change in much more detail. But the idea with this model that we really want you to take away is that you'll see that there are these arrows going between the different stages of change, and it's represented as a circular model. So it's easy to think of it as linear, but it's really important to remember that people can enter and exit through the stages of change really at any juncture in here. And that's actually a really important part of the psychoeducation part of it as an assessment tool. Patients can get very demoralized if they feel like they're moving backwards because they've exited and entered at a part that they think of as earlier. And so one of the ways that we can actually help them to understand that they are making progress every time they move through the stages of change is by comparing it to a spiral staircase. So even though there is this kind of revolution that they're making going through these various stages, it's you can explain it as, yes, you've turned the corner and it feels like you're back where you started because you're back in a familiar situation. You're on this spiral staircase, so you actually are moving upwards, even though you're kind of returning to a familiar phase. So it's really important to emphasize that no matter how they've moved through these stages of change or how they continue to, every juncture is a learning experience that's going to help them make better informed decisions in their future revolutions through it. The other thing I'll note about this model before we get into detail is that you'll see that relapse is baked in that upper left-hand corner. We very much do consider that part of the stages of change that is indivisible, and that's an important part as well for psychoeducation with patients. We do want them to know that relapse is not only normal, it is to a great degree expected, and that can really help them with the demoralization that otherwise comes with slipping back into old habits once they've already made some great progress. And one of the progenitors of the stages of change, Carlo Di Clemente, has a series of beautifully written essays talking about how it really is a paradigm change to help people understand that relapse is not a sign of failure. In fact, it's a very rich learning opportunity. So an important part of framing the stages of change there. Let's look more closely at the identifying characteristics of each of these stages. The one that is often situated as the first is pre-contemplation. So that's when a patient is just not considering change at all at that time. In contemplation, there's the consideration of change and it's in the foreseeable future, but this is where people are really on the fence. They're very much identified with the status quo. It's very clear to them that there are a lot of benefits to staying the way things are, but they're also starting to realize, hey, things could be really good on the other side of the fence as well. In preparation, number 3, they're planning on change in the immediate future. So that means they've chosen the side of the fence and they're trying to figure out how to get further along. In action, they've recently made meaningful change. So that's about really, putting the plan into action. And then number 5, maintenance, that's where those action steps have become sustained in a stable way in the person's life. So it's starting to become the regular behavior rather than a new behavior. And then again, remembering that number 6, relapse, is very much a part of the model, and that's a return to prior targeted behaviors as well as a learning experience, as we mentioned. And we really emphasize with relapse, that is very, very normal with any kind of health change behavior. It's not just substance use. So looking more closely at how we match the stage to the intervention. In pre-contemplation, you're really just looking at rapport and alliance building on strengthening the relational currency of the provider relationship. You really don't want to push too much, which people are very tempted to do. At most, in terms of MI interventions, you might do something very light, like a decisional balancing exercise, which is a sort of 2x2 pros and cons exercise, just to help maybe clarify or bring to the surface if there is any sort of incipient ambivalence. But there's a real danger with pre-contemplation of pushing people further into it if we push too hard. By contrast, contemplation, that's the gold zone for motivational interviewing. So again, that's where people are on the fence. MI is all about helping them kind of pick a side and act on it. So that's really where MI fits best. And there's a danger to applying it too early, or if you try to apply it in the later stages, you can actually push people back towards pre-contemplation by sort of reminding them about what was great about the status quo. And then, of course, once you're in preparation, action, or maintenance, MI wouldn't be helpful anyway, because it's really mostly about planning. How are we going to make this change? Skill building. How are we going to sustain this change? Relapse prevention. How do we, protect all the successes that they've established? So diving into more detail in pre-contemplation, a person may not recognize there's a problem. They haven't thought in a serious way about changing. So here again, the goals are really about rapport building and bringing an awareness of the problem to the surface so that they can start thinking about it. Keeping them engaged in the process, again, a very relational aspect. So that's about listening to their concerns, reflecting their content and emotion to help them clarify what's really going on at their surface. You want to elicit more information. A lot of that can be about past experiences, especially current strengths and attitudes. We often find that somebody who is in pre-contemplation might have a bit more of a motivation for change than they think they do, but they might be being held back by confidence issues, self-esteem issues. So when we can dig into past successes and figure out, do they have currency to change, so to speak, interpsychically, then we can really elicit that. And lastly, communicating caring, empathy, honesty, and acceptance so that they feel safe in their relationship, which allows them to make change as they're ready. Next, in contemplation, they're willing to think about making a change, but not yet ready to do something about it. Again, goal is to move them towards action. This is where MI fits best. You keep the person talking about change, and a sort of subtle part of MI that's really critical is basically just kind of, in a very gentle way, ignoring what we call sustained talk, which is the talk that kind of reflects the status quo, whereas you really amplify when they start talking about change. So in that way, you're boosting the person's awareness of their change options, and you're increasing the perceived benefit of change from their perspective. So very importantly, that's not about why you think change would be good for them. It's helping them to recognize, how is this going to be better for me? So part of that is by developing discrepancy. When you hear them talking about the ways that the status quo does not fit into their life, you reflect that. You make sure that you're kind of amplifying that ambivalence. You're exploring, how does this fit with your values and goals? Reflecting what is the intention behind change, giving that feedback where they can start to notice, yeah, now that I'm hearing myself say it, I guess actually it does make a lot of sense to make this change, but man, it would really be difficult. So they're really kind of gaining more awareness about why they want to make this change. Addressing discord, this is all about making sure that you recognize when you're pushing too hard and that you change tactics, because MI is all about, they like to say it's about dancing rather than wrestling. So if you notice that discord has come up, you step back, you move to those pre-contemplation strategies, and you go back to just rapport building, to empathy, to alliance building, instead of trying to argue or coerce. So the strategies there are apologize, affirm, accept. You really want to reflect the other concerns. A classic approach here is that you reframe that term yes, but as yes, and that's a way to help them break up that black and white thinking and to have a little more nuance. So a sort of classic there would be something like, they are saying, yes, I do want to change, but it's just too hard. And you reflect back to them, yes, this is a change that's really, really important to you. And also you're nervous because it's going to be very difficult. And this helps them to think, okay, both are possible at once rather than either or, which is that sort of more antagonistic stance. Then lastly, you're supporting self-efficacy. You're really wanting to evoke their autonomy. You want to help them review their past successes, again, to help build that confidence, instill a sense of optimism, make sure that they are really aware of their own sense of commitment and their decision-making ability. With action, a person in the action stage is ready to make an initial attempt to change behaviors, but they might not be confident about their abilities to succeed. So that's a lot about skill building. Your goal here is to smooth the path for them, right? So you're reducing barriers, sometimes in a very concrete way. Sometimes that's about problem solving. How is this going to fit into their schedule? How do we get people in their lives on board? But it's also about being a cheerleader to some extent. You really want to encourage their progress. You want to make sure that they're recognizing the change that they're making, even if it's very incremental, because they often don't recognize that. And then lastly, and this is really more important than one might think, you want to restrain excessive change. So people sometimes get really excited about the momentum during the action stage, and they end up biting off more than they can chew and setting themselves up for failure in that way. So when you recognize that that might be happening with a patient, it can be hard to do as a provider. You really don't want to rain on their parade, but it can be helpful just to sort of predict, hey, you know, something that's really common is that when people get carried away with making all these changes at once, it's just not sustainable, right? And that the sustainable changes are the more incremental ones. So relapse, I can't say it enough, normal part of the process, and we really want to communicate that and meta-communicate that to the patients. It's a common occurrence in the process of recovery of any kind of health behavior. It is absolutely not a sign of failure. It can be really helpful for substance use disorder patients to see this as part of chronic illness management in general, comparing it to, for example, medication compliance with diabetes or blood pressure. Remembering that the way we talk about relapse, both in general and the specific language that we use, can really profoundly affect our patients' morale as well as their commitment. So when we can frame relapse as a learning opportunity, as an opportunity for them to say, hey, now I definitely know what doesn't work, or I know what the danger signs are, these sort of things. And then also to predict what's called the abstinence violation effect, which is something that's really, really common with behavior change, where somebody has been in the maintenance phase for a while and then they have a slip, right? Where they return briefly to the old behaviors and they have this feeling of, I've lost it all, right? Because they have this kind of all or nothing thinking about it. And they think, well, I might as well give up, right? And so they throw the baby out with the bathwater. So if you can predict that that's likely to happen, because it is very likely to happen if people don't know about it, then you can say, hey, you don't have to give it all away if you have one slip. You can nip it in the bud and you can get back on track. I had a patient once describe this as don't let a slip become a snowball. And that's pretty much the phrasing that I use all the time for patients now, because I think that's a really good imagery to use to say, you can stop it while it's small. You don't have to let it turn into this big thing. You don't have to go all the way back to pre-contemplation. So again, your goal is here to avoid them becoming discouraged and helping them re-engage in the change process, ideally closer to where they were than going back to pre-contemplation if possible. So we're going to pivot now to motivational interviewing in the spirit of MI. Again, not the same thing as the stages of change model, but there's a reason that they're closely identified. So big picture, motivational interviewing is an effective method for talking with people about change. And that's emphasized because Miller and Rolnick really make a point in their writing. Miller and Rolnick are the progenitors of MI. In saying that it bothers them when they hear people phrase it as, you know, I did MI to somebody or I MI'd somebody into ... And they really want to emphasize MI is not a verb. It's very much a collaborative process. It's about being with people or perhaps for people, but definitely not to, which is this very paternalistic stance that providers sometimes can slip into. So it's a collaborative person-centered form of guiding to elicit and strengthen motivation for change. So guiding in contrast to, say, leading or pushing. And it's a clinical method used when a person may benefit from making a behavior or lifestyle change and is reluctant or ambivalent about doing so. So again, remembering contemplation is the gold zone for MI. That's really the specific area or the timing when it's best applied. So 10 things MI is not. This is actually taken from a somewhat sassy article that Miller and Rolnick wrote a little while ago because they saw MI being kind of over applied as a description to a lot of things that might be related or might actually be very unrelated. Just because MI has become almost ubiquitous in a lot of areas of healthcare, and unfortunately the downside of them having chosen not to make it proprietary is that they don't get a lot of quality control. So they really want to emphasize it is not the trans-theoretical model of change, as we've discussed. They came about around the same time, and of course are closely related, but very different. A way of tricking people into doing what you want them to do. And this is a point that's clearly a thorn in their side. And they talk about hearing providers who don't know much about MI thinking that it's this sort of hypnotism technique where you just magically change people's mind in the opposite direction. And of course, that's anathema to the spirit of MI. It's all about helping people to do what they already have some kind of motivation to do. 3, it's not a technique. We'll talk more about how the spirit of MI and the overarching philosophy is the most important part, although there are very important strategies that go along with it. It's not decisional balancing. I think this is a sore point for them just because people sometimes think that if they do a pros and cons matrix, they're doing MI. And decisional balancing is actually one of the rarer strategies that's identified with MI if you're using it correctly, because they caution you to use it judiciously in case you accidentally send somebody back into pre-contemplation by eliciting more sustained talk than change talk. It's not assessment feedback. This one's kind of easier to explain. Motivational enhancement therapy is a very closely related, it's an offshoot of MI that includes assessment feedback. And people sometimes think that motivational enhancement therapy and MI are the same thing, but actually assessment feedback is not a standard part of MI. It's not cognitive behavioral therapy. Miller's background is in CBT, but he really emphasizes that it was a paradigm shift for him to turn away from this sort of pedagogic model of CBT, where you're assuming that the client has a deficit and you are providing them education to fill that deficit, towards this more client-centered therapy of MI. But they also want to emphasize, while MI is very fundamentally humanistic, it is not client-centered. Carl Rogers would be very upset about the idea of a goal-directed therapy, which MI very much is. 8, it is not easy to learn. A lot of people will see it skillfully done, for example, in a video, and will think, well, I could do that. But it's one of those things, they compare it to, say, playing the piano or ballet, where the whole thing is if you do it really well, it looks easy, but there are actually hundreds of micro momentary decisions where the provider is just gently shifting direction, and that's not clear unless you actually know what they're doing. Relatedly, it's not practice as usual. MI is one of those approaches where when you see it in action, it makes so much sense that a lot of providers sort of recognize a part of their own clinical intuition in it and think, oh, I'm already doing that. But actually, it's much more complicated and it requires quite a lot of skill to practice. So I think it's a sore point again for Miller and Rolnick to hear people say, oh, I already do MI, when they actually haven't had any training. And lastly, and importantly, it is not a panacea. And this was sort of a twofold thing that they explain. It's really it should only be narrowly applied. It's specifically for people who are in that contemplation stage. And while a patient may return to the contemplation stage many times throughout treatment, you really don't want to use it very often at all outside of the contemplation stage. You can actually do a lot of damage and send people further back into pre-contemplation, again, by reminding them about their reasons for the status quo. The other side of it's not a panacea is a lot of healthcare providers will complain that their colleagues, their interdisciplinary colleagues who have heard great things about MI and maybe seen it in action, will say things like, go MI this patient into medication compliance. So it's just a misunderstanding of how and when it can be used. And I think because MI is so spectacularly successful when it is applied correctly, there's this temptation to just use it for everything. But again, it only applies at a very specific time and juncture. So the research evidence, I'm just going to hit a couple of highlights there. An earlier meta-analysis, so this was 2005, showed that adding MI to the beginning of treatment led to sustained outcome improvements. Again, that's remembering that contemplation is that gold zone for it. And really importantly, as we're about to talk about the spirit of MI, outcomes were actually better when no manual was used. And that sounds weird, but Miller and Rolnick addressed this, and they did a psycholinguistic analysis that showed very clearly what happened here. And that was because in 2005, MI was still in its early stages. It still had sort of vestiges of CBT. And in that case, the manual had a stipulation that you had to create a change plan at the end of the first session, irrespective of where the patient was at in their change stage. And so obviously, as we've talked about, that's going to send people who are not ready yet further back into contemplation. It's actually going to do a little damage. Whereas the practitioners who didn't have a manual and were going more with the spirit of MI, we're going to recognize, no, this person is not ready for a change plan, and therefore it's going to be a lot more effective because they're not pushing them backwards. So a really interesting demonstration of the point of the spirit of MI there. Then a more recent meta-analysis with health behaviors with a primary care population showed that the effect sizes were largest for outcomes related to weight loss, blood pressure, and substance use. For providers here, this is pretty impressive. These are all considered to be fairly intractable problems in a lot of senses, and also that it's useful in as few as one session. So MI really is the ultimate brief intervention in that sense. For purposes of time, I can't dive into culturally adapted MI, but I did want to put it all on your radars because this is pretty recent research. MI is really well suited to being culturally adapted. In fact, there's some evidence that the effect sizes are slightly larger for racial and ethnic minorities. They think probably because this is all about, making sure that the treatment fits the patient rather than, vice versa in the Procrustean bed. And what they call the 3 C's of creating culturally adapted MI are content, where you're making sure that you incorporate unique cultural values, customs, and tradition into treatment planning. An example here was the recognition that traditional health messaging around tobacco is very negative, and that for American Indian and Alaskan Native patients, that could be very aversive because tobacco has a much more multidimensional role in their culture that involves rituals and a spiritual aspect. Concepts, which is about reframing the treatment model to match the cultural importance of either specific character traits or their cultural importance in terms of emic or edic values, emic meaning within culture, edic from without. An example here, and this actually relates really nicely to Dr. Godomsky's recent presentation about policy and structural factors that affect substance use disorders, was about emphasizing the framing of substance use disorders as a community level rather than an individual disorder, specifically that stemmed from disparities between Black and white American communities. So much less individualistic and pathologizing and taking a much larger epidemiological, sociological lens there. And then context. So that's considering things like acculturative stress, economic or political macrosphere factors, relationship to the country or culture of origin. An example here was a version in which the providers specifically identified and discussed the effect of low status employment, social isolation on drinking behavior, and elicited what mattered to the participant in that respect. And so that was specifically with the Latino population, and that helped them to clarify the cultural priorities with that target population. So again, would love to dive more into that if we had more time, but I do want to put it on your radar because culturally adapted MI is pretty exciting and kind of new. So now we'll wrap up with the spirit of motivational interviewing, which is nicely encapsulated by Blaise Pascal's quote from several hundred years ago. People are generally better persuaded by the reasons which they have themselves discovered than by those which have come into the minds of others. So if that's all you take away about the spirit of MI, you'll be doing pretty good. It really does sum up that idea that we cannot foist our values and intentions and goals onto our patient and expect them to sustain those changes. It's really about what they can come up with on their own terms. So firstly, it is the spirit of MI to appreciate ambivalence. Ambivalence meaning that we can feel two seemingly contradictory things at once. And it's very easy with patients, if we're not tuned into ambivalence, to see this presenting as what looks like lack of motivation or resistance because they're literally at war with themselves on the inside, but it might show up as inaction, just inaction on the outside. And what you're looking for with ambivalence is to emphasize that it's a normal part of the change process. It's very common prior to as well as during habit change. And what it can lead to is a communication trap. So that's where we argue one side and that naturally elicits the other person to defend the other. It's an interesting phenomenon called psychological reactance, and it's very much a part of human nature. So the idea is there's this saying of, if there's 2 dogs in a fight, which one wins? It's the one that's better fed, right? And so when we conceptualize ambivalence in MI, one way to think of it is we want to feed that dog that's about the change process, that's about the positive change rather than the status quo dog. And when we get into the communication trap, we're accidentally feeding the status quo dog because we are eliciting the person to defend the status quo. Whereas if we sided with them, they wouldn't feel the need to do so. So that actually makes change less likely when we prompt them to defend the status quo. So we call that the righting reflex. That's the natural inclination we have to make it better for another person, very well intentioned. The danger is that we end up telling the other person what to do and how to do it and why they should do it without really understanding in a deeper, sincere way what's important to them about it. And it creates that resistance and it causes us to move away from that alongside partnering stance of MI and into that paternalistic expert top-down rule. So why does the writing reflex happen? There's a lot of underlying assumptions here. The big ones are they just don't see it, they don't know how, they don't care. It's this deficit model, right? And so we respond with a writing reflex, which is I'm going to give them that insight, give them the knowledge, give them the skills. It's not to say that insight, knowledge, and skills are not helpful later on. For action, maintenance, planning, those can be very helpful. In contemplation, it's mostly just going to cause them to escalate to the status quo. So we really want to step back from that and look at what their insight, knowledge, and skills already is and make sure that we're not foisting ours on them. The consequences of the writing reflex, there can be quite a few, but these are the common ones. They might make a change briefly. Maybe they like us as a provider and they're like, okay, I'll give it a shot. But it's, as we all know, it's very difficult to sustain behavior change that isn't freely chosen. And so usually they're not going to be able to sustain that change. It might be that they listen politely while they're in your office and then they go ahead and they do whatever they were going to do in the first place. I think we all have had experience with that with patients. It may be that they protest, we push harder, and we both descend further into that communication trap with the writing reflex. In any case, no one benefits, and very often the impulse is to blame the patient and say, oh, it's because they're not motivated or it's because they're resistant, when in fact what we're doing is falling into that trap when the ambivalence is present. So a little depiction here to help us remember that when we engage with ambivalence with the writing reflex, we're accidentally strengthening that muscle of ambivalence towards the side of the status quo. So what can we do to counter the writing reflex? We have a handy acronym in MI called the RULE. The first part is literally just awareness. So R is resist the writing reflex, recognize that it's there, it's very seductive, it's human nature, resist it. Move to the other side. It's sort of the positive opposite idea. So you understand your patient's motivation. You really want to align with them. You want to make sure that you're using accurate empathy, listening to your patient. You're helping them to clarify, well, what is important to this about me? And you're empowering your patient. You're seeing, not only why is this important to you, but what do you know about yourself? What are your strengths? What have you accomplished in the past that's going to help you move towards this? So it's not about you telling them what they're going to do or how they're going to do it. It's about eliciting how that's going to happen to them or for them and why. In terms of components of MI, again, Miller and Rolnick really emphasize that if you have to choose one part of it, go with the spirit. They've written a lot of essays saying it's really disappointing to them when they see really formulaic applications of MI because you might know all the skills and techniques, but if you're not integrating them with the spirit, those are really empty shells because the spirit is really the main mechanism of change in MI. So spirit is broken down into acceptance, collaboration, evocation. Acceptance is that very humanistic part. Absolute worth or accepting your patient, having that positive regard in the absence of judgment. So in substance use disorder, that very often means regardless of whether they continue their old health behaviors or not, you still care about them just as much. It's not in any way contingent on changes that they may or not make. There's what's called the Rogerian paradox here, which is that when people actually experience being accepted as they are, they no longer have that need to defend their status quo or the way they used to be, and they are freed up to make this positive change. And that's just one of those superordinate factors that really is invaluable beyond measure, and it's also difficult to accomplish. With accurate empathy, again, that's about striving to understand the other's internal perspective, not making assumptions based in your own perspective, making sure you're absorbing the meaning and values that's coming through their eyes rather than bringing your own in. And then autonomy support, really acknowledging their freedom to make choices. That can look like, this is absolutely your choice. You always want to affirm, hey, this is not me making this decision. You are making this choice. All I can do is support you in making a decision. I'm very happy to do that. And lastly, affirmation, really communicating appreciation of their strength and effort. Sometimes that looks like, yes, you didn't do any of the things you thought you were going to do this week, but you showed up to this session, and that's really important. So you're really capitalizing on whatever incremental changes they are making towards positive change. So compare and contrast with acceptance. In autonomy, the provider is affirming the patient's rights and capacities, and they're honoring them regardless of their using behaviors. Whereas with an authority stance, the provider is telling the patient what they need to do. And there's this assumption that they can't make informed behaviors if they are continuing their old health behaviors, that they need to be told or instructed what to do. With collaboration, again, that's that coming alongside stance, so active collaboration between experts. There's that imagery again of dancing rather than wrestling, exploring more than persuading. And again, with the language, remembering that it's conducted for and with a person rather than to them. Patients are always the undisputed expert on themselves. And there's that idea that patients usually know what they need to change, and often they actually know how to do it. So again, it's the guiding and the supporting. Compare and contrast, collaboration is where the provider is developing a partnership, honoring the patient's expertise and perspective, as opposed to confrontation, where the provider is required to sort of impose their view on what's considered a patient's deficient perspective. And lastly, evocation. The idea is they already have what they need. You're there to help bring it forth. The motivation, the resources are already within the patient. They're often going to feel like they're not ready. And part of your job is helping them to recognize, even if there's never a perfect time, they do have what they need if this is what's right for them. So you're evoking and strengthening their why. Why is this important to them, not to anybody else? And understanding the patient's perspective and wisdom in that process. So lastly, that compare and contrast, you're enhancing the intrinsic motivation for change by eliciting their own perception of goals and values versus this education stance where you're kind of remediating deficits by inputting education, assuming that they don't have their own knowledge. So again, that summary image, and I think that kind of nails the feeling. Sometimes you realize you've slipped out of MI where it feels like this wrestling push-pull, whereas when MI is going really smoothly, it does feel like this partnership, like this dance that flows forward very naturally. I know that was really, really fast, so I'll stop screen sharing and look to see if there's any questions.